Thank you. Thank you very much. It's a pleasure to be here, and thank you all for coming. I'm charged with the task of talking to you about androgen deprivation therapy or hormone therapy. And what I've chosen to focus on is understanding, preventing, and managing side effects of hormone therapy. There's a lot of ground to cover, so I'll try and deal with it at a higher level, and I'm sure there will be questions on different aspects, but I hope I have struck the right balance between giving an overview and enough detail that there's new information in this for you. My disclosures are listed there. Oh, I'm sorry. I think it's automatically advancing. And I get funding from a variety of agencies, and also one of the drug companies that's given us funding for one of our previous clinical trials. Because there's so much to cover, I won't be able to cover it all, but I'm certainly happy to answer questions, and I've chosen some of what I think are the key issues within advanced prostate cancer for men who are on hormone therapy, and I hope to cover these with you tonight. What I'm going to do is to briefly introduce the area of hormone therapy, the concept of side effects from hormone therapy in principle, and why there are so many organ systems or parts of the body that are affected. We'll then talk about some of the key side effects in the areas of bone, cardiovascular, metabolic, muscle, fat, psychological areas of the body, and then I'll summarize. So let's start off with an introduction to hormone therapy. So androgen deprivation therapy or hormone therapy or ADT, I'll use probably the term ADT through the rest of the talk, really refers to a series of different treatments that modify the body's male sex hormones or androgens. There are 4 major modalities that are used to do this, and the reason these are done is because testosterone, which is the main male sex hormone, is a stimulant for prostate cells to grow. Whether those are normal prostate cells in the body or they are prostate cancer cells, it is a nutrient that lets those cells grow. It is a hormone that stimulates them. If you block or reduce testosterone levels, you reduce that supply of nutrient and stimulation, and those cells will go to sleep or they will wither and die. And the hope is that you control the prostate cancer cells by cutting off testosterone supply. How do we do this? It's a very sensitive mouse, sorry. There are 4 major ways in which this is achieved. In the old days, when this was first described way back in the late 1940s, it was orchiectomy, which is a surgical procedure that removes both testicles and leads to a rapid reduction in the production of male sex hormones by about 85 to 95% reduction in levels in the body within a span of 2 weeks. These days, very few people get surgical therapy to cause castration or androgen deprivation. Instead, options 2 and 3 are the most common. Injections of either agents that stimulate a hormone in the body that leads to eventual reduction in testosterone, and these are the GnRH agonists, and the most common of these are drugs like Zoladex and Lupron, or injections that block the same hormone that stimulates testosterone, eventually leading to reduction. Now you may look and say, well, one stimulates the hormone prior to testosterone, the other blocks it. Because the body normally makes testosterone through this GnRH in a cyclical fashion, meaning that it goes up and down every day in the body, if you give a constant stimulus to the body, it eventually just shuts down production. It takes a few weeks, but both agonists and antagonists eventually lead to the same reduction in testosterone and related androgens. And finally, there is a 4th agent or set of agents, which are tablets, called non-steroidal anti-androgens, and they block the action of testosterone in the tissues and in the receptors in the body. They're often used in combination with the injections in order to get not just 95% reduction, but 99% reduction of testosterone. And that's sometimes called combined androgen blockade, or total or maximal androgen blockade. Because although the testes in men is responsible for about 90 to 95% of our male sex hormones. Another 5 to 10% is made by the adrenal glands, which sit on top of our kidneys. So these tablets block that extra 5 to 10%. Why do we give hormone therapy? There are two main indications that we have the strongest evidence for. The first is in combination, or what we call adjuvant, to either radiation or surgery, radical prostatectomy, that is used to treat high-risk disease. And I'll come back to the definition of that in a moment. And they are used in combination for, on average, 2 to 3 years after the radiation or the surgery. The second is in men whose disease has spread throughout other parts of the body or metastasized. I apologize if any of the terminology I'm using is foreign. I'll try to define the terms, but I know many of you are very educated and sophisticated in this, so I suspect you'll all know what I'm talking about. But when the prostate cancer spreads to other parts of the body and becomes metastatic, then hormone therapy is used in those two indications. There are two other indications where it is used sometimes, but the evidence to support its use in those settings is not as rigorous or robust on the basis of clinical trials. Those two settings are when the PSA levels start to rise after prior surgery or radiation, or in men who do not have metastatic disease, but also do not want primary treatment of surgery or radiation, and sometimes the oncologist will put them on hormone therapy as the only treatment of disease that has not spread. These two areas are used less commonly, and there is less evidence to support them, but at an individual patient level, there are indications when one would want to consider ADT in these instances. But for indications 1 and 2, we have strong evidence. So how strong is the evidence? I'm not going to go into it in detail because that's not my focus. But in the setting of high-risk disease and metastatic disease, the evidence is very robust. For example, there are 22 randomized controlled trials, RCTs, Winston, wherever, I don't see you, wherever you are. That's what an RCT is, a randomized controlled trial. The strongest scientific evidence in favor of a treatment. At least 22 of these trials have been done and shown beyond any reasonable doubt that ADT improves quality of life and symptoms from prostate cancer. It slows progression of the disease. It prolongs survival in men who have metastatic disease and in men with high-risk disease. For example, how big is the benefit? If you have high-risk cancer and you're going on radiation, and high-risk cancer means Gleason 8 to 10, or clinical stage T3 disease, or a PSA greater than 20, or all of the above. If you add ADT on top of radiation, there is a 15% improvement in overall survival at 5 years. That's pretty big. So these are not subtle or small benefits in these settings. In the other two settings, the evidence is not as strong as I mentioned. For those who can't read the text at the bottom, it says, this medication won't cure you, but its side effects will. So I'm going to jump into the main focus, which is side effects and why. So first of all, most men who go on ADT are on it on average for 2 to 3 years, sometimes intermittently, where you're on for a period of time and then off, or else continuously. And that treatment will typically last 2 to 3 years, but sometimes will last for the rest of their life, especially if they have metastatic disease. Because testosterone is a major fundamental hormone in men, and to a lesser extent in women, if you suppress levels of testosterone, the entire body is deprived of this male sex hormone, which has far-reaching consequences. For example, if one looks at this diagram that came from one of the review articles on the side effects of ADT, you will see that a variety of domains get affected. Sexual function, bone health in terms of osteoporosis, diabetes, problems with cholesterol, cardiovascular side effects, issues in the muscle, fatigue, cognition, mood, anemia, etc. All of these areas theoretically can be affected, and I'm going to try to cover some of these. Ooh, the red doesn't project so well. I'm going to cover 5 of these main areas, or 6 I should say. I'll cover osteoporosis, diabetes and cholesterol, cardiac, muscle and bone, muscle, and cognitive/mood. So those are the areas I'm going to talk about, but I'm happy to spend some time, if people want, on some of the other side effects like fatigue, sexual function, breast enlargement, anemia, etc. But I can't cover it all. So because there is such a profound suppression of testosterone, you drop your levels, as I said, by over 90% in a span of a few weeks after starting these treatments. It is a rapid and profound decline. In contrast, as men get older, there is an andropause. By the time we are 40, and by the time we reach age 70, our testosterone levels will have dropped on average by between 30 and 50%. That's over 30 years. ADT drops at 90% in 2 weeks. Big change on the body, huge challenge. Many, many organs and tissues throughout the body have testosterone receptors. You drop the levels of testosterone, so many organ systems may be affected. That's why the side effect list is potentially so long. Let's go into the first main area, which is bone. So ADT is associated with progressive loss of bone density or bone strength and leads to an increased risk of osteoporosis, which I'll define in just a moment. The highest rate of loss of bone density is in the first year of ADT use, but every year you stay on it, there are ongoing slow but steady losses in the vast majority of men who are on it. Depending on the level you start at and how strong your bones are, this may or may not be clinically important in your lifetime, but for many men who already have vulnerable bones, this can lead to osteoporosis and an increased risk of fracture. In the first year, the rate of loss is about 2 to 5%, and in subsequent years, it's closer to about 0.5 to 2%. But if you continue on ADT, the bones will slowly get weaker. If you're on intermittent ADT, where you're on for a period and off for a period, during the off period, there is some recovery of bone, but never completely. So once you've been on for at least 6 months, there will be some degree of permanent bone weakness. If you're only on for a short time, it's quite minor. If you're on for several years, it can add up. What does this lead to, besides just a number in terms of bone density? It leads to osteoporosis. What is osteoporosis? Many of you in the audience will know, particularly the women, because women are very aware of this disease, but it is also a man's disease. Osteoporosis is a condition of low bone mass and is characterized by fragility of bone, so easily breakable, and low bone mass. The bone is not as dense or strong as it once was. The consequences of osteoporosis are many. There is up to a 20% increase in mortality within the first 10 years of a diagnosis of osteoporosis. It impacts on quality of life. It can lead to impaired function and pain, fatigue, and depression if you have a fracture. If you have no fracture, you will have no symptoms. And that's what makes this a silent disease until the first break. The lifetime risk of a fracture for men who are over the age of 50, this is no prostate cancer, no ADT. Every man over the age of 50, your lifetime risk of an osteoporosis-related fracture is 13%. If you go on ADT, that risk goes up. On the left, we see what a normal bone looks like when you get rid of the fat and the muscle and the nerves in between. These are struts that are made of calcium and other proteins and minerals. This is at a very microscopic level inside your bone. A small piece of bone is taken, and you have all these struts that give the bone its strength, like scaffolding on a skyscraper. In patients with osteoporosis on the right, you have a couple of key things. The bone gets thinner. Each one of these little spicules inside the bone. There is more space in between, and some of the horizontal and vertical struts are lost. They disintegrate. And any of you who do engineering know that the more horizontal and vertical structures you have attached to one another, the greater the overall strength. So you start cutting these bridges, and you start thinning the bone, higher risk of fracture because the bone is more brittle and fragile. Whoa, sorry, it's flipping just way too fast. Okay, major parts of the body where osteoporotic fractures are often seen, particularly with a fall. It doesn't have to be a car accident, doesn't have to be a fall downstairs. It could be just onto the level ground from standing height. The wrist, the spine, and the hip are the big three, but any other major long bone in the body is at increased risk of fracturing in people who have osteoporosis. How common is it? Important fact for all of you who are 65 or over. Even if you have not started ADT for your prostate cancer, at least 5 studies have shown that 20 to 40% of men already have osteoporosis. And because it's silent until you have your first fracture, Unless you go looking for it, you will not know. And that's an important point that we don't appreciate. We think it's a woman's disease, but in fact, it is still common in men. If you go on to ADT, within 5 years of being on it, another 10 to 20% will develop osteoporosis. That's the risk. But the risk is dependent on what your starting bone density is. The better it is in the first place, the less likely you will develop osteoporosis. In 5 years, the excess risk of fracture is another 5 to 7%. Remember, 13% risk in your lifetime, 5 years of ADT, another 5 to 7% increased risk of fractures. So, increased risk of osteoporosis, increased risk of fractures. What can you do about it? First thing is, prior to starting ADT, know your bone density. Get a simple bone density test, which takes 15 minutes, a little bit of radiation, less than a chest x-ray, no pain, easily done in many labs around the province, and it's covered by OHIP. Prevention includes taking calcium, about 1,000 to 1,200 milligrams from all sources. That means diet, plus your tablets if you need any. And there are lots of good calculators online to help you figure out how much calcium you're getting in your diet. Vitamin D is recommended. On average, I recommend 1,000 units a day for my patients. And in men who are high risk of fracture, based on your family history, based on your bone density, etc., there are medications, prescription drugs that can reduce the risk of fracture in men as well as women. These drugs are used in osteoporosis, and they are also effective in men on ADT. The next area is cardiovascular. This is the most controversial side effect from androgen deprivation therapy, and it remains a controversy today, just like it was the last time and the last time before that I gave this talk. There are multiple studies that have suggested there is an increased risk of cardiovascular outcomes. Increased risk of heart attack, maybe increased risk of stroke, increased risk of fatal rhythm disorders, and sudden cardiac death with ADT. There's at least one randomized controlled trial that showed this. There are 2 large databases that were using administrative data from people who are getting it for billing purposes, and 1 large clinical database of men with prostate cancer. However, there are an equal number, if not more, of randomized trials, administrative databases, including one that I did in Ontario, and clinical databases that suggested no increased risk. So this is where there is some data saying yes, and some data saying no. A meta-analysis which tried to combine all of these data together that was published a couple of years ago said, we're still not sure because overall the evidence is inconclusive to date. Most people believe that there probably is a small increased risk, but the risk is fairly small compared to the large benefit in survival for men who have advanced prostate cancer. So one has to put that in context. What we also believe at the moment, and there's a few studies now that have shown this, is that the risk seems to be higher in 2 groups of people. Those who have pre-existing heart disease, whether that's angina or a previous heart attack or bypass or angioplasty, and in men who are over the age of 65. The risk seems to be higher than in younger men and men who have no pre-existing cardiac disease. How high is the risk exactly? Well, it's controversial and we don't know for sure. Our best estimate seems to be a 1 to 5% increased risk of 1 or more of these cardiac events over the span of 2 to 5 years. And what can we do about it? Forward 1 slide, please. Thank you. The prevention and treatment of heart disease in men on ADT at the moment is no different than in men who do not have prostate cancer and are not on ADT. We are trying to optimize the same cardiac risk factors. Treating high blood pressure, optimizing cholesterol, treating diabetes, stopping smoking. Stopping smoking. Did I say that already? And stopping smoking. The most powerful thing you can do for your health if you smoke. If you don't smoke, you're okay. Reducing obesity and making sure people remain physically active. All of these are known to be associated with a higher risk of heart attack and sudden cardiac death, and we can treat and help people with each and every one of these. The next condition, thank you. Next slide, sorry. The next condition I'm going to talk about, next slide please, thanks Kos, is diabetes. So most of you know what diabetes is, but for those who don't, it is a condition where people's bodies have difficulty managing blood sugar levels. Every time we eat, the body digests the food, our blood sugar goes up, the body makes insulin and other hormones that bring the sugar levels down, because high blood sugar damages proteins and damages our body. With diabetes, we cannot make insulin either at all, or we make insulin inefficiently when we are exposed to sugar in our bloodstream. 4 large studies to date, including one that my group did here in Ontario, have shown that there is an increased risk of diabetes in men who go on ADT. There is little controversy here. Everybody agrees in all the studies. And ADT in men already who have diabetes is associated with more insulin resistance, meaning the insulin doesn't work as efficiently in our tissues, and worsening of blood sugar control in those who have diabetes. And those things are potentially important for all of us, because remember, men with prostate cancer, the #1 cause of death is still heart disease. #2 may be prostate cancer, but in many men, it's still your heart. And one of the big risk factors is diabetes, and so we need to be aware of this. The absolute risk of developing diabetes when you're on ADT over 5 years is still relatively low, about 1 to 2%. So we're not trying to scare people, but we're making people aware. The risk is higher in 3 main groups. People who have a family history of diabetes seem to be at higher risk. People who are overweight, you can calculate your body mass index, but typically if it's over 27, your risk goes up. In South Asians and in Southeast Asians, it's even above 25. And maybe with older age, above about age 65 or 70, the risk goes up. What can you do about it? First and foremost, before starting ADT, my recommendation and that of many guidelines is get your fasting blood sugar checked once. And then after being on ADT for 1 to 2 years, get it checked at least once more to make sure that you have not developed diabetes. And for those who want to prevent it, there are dietary things one can do to try to reduce the risk. Certainly losing weight if you're overweight, increasing physical activity regardless of your body weight can help with managing insulin and managing blood sugar. And high-risk patients, and there are criteria to define them, I don't have time to get into them right now, but there is a prescription medication that is used to treat diabetes, metformin, but it is also used to prevent diabetes in high-risk populations, including men on ADT who are otherwise high risk of diabetes. So you can talk to your physician if you may be in this category. Most people don't need the medication. They can manage with these other strategies. Another metabolic condition that is somewhat related to diabetes and heart health is, of course, cholesterol. And multiple studies have shown that the body of men on ADT changes in a number of important ways. We gain fat mass, meaning the total amount of body fat goes up. You lose muscle mass, which has implications in terms of many aspects of health. But you also have changes in cholesterol or lipid components. So lipids are blood fats, and cholesterol is the other name for it, but sometimes you'll hear it called lipids and cholesterol. They're similar. Total cholesterol levels will go up, which is bad. They go up by 7 to 10% on average for men who are on ADT. The bad cholesterol goes up by about 0 to 7%. The good cholesterol goes up in most studies, although there was an exception in one. And blood fats go up by 10 to 26%. Altogether, this combination of changes in lipids or cholesterol is thought to increase the risk of heart attack and sudden death. And one more reason why one needs to know your cholesterol. Most of these changes in lipids or cholesterol occur within 3 to 12 months of being on ADT, but once you're on it longer, they don't continue to get worse. Most of the changes occur in the first year, and then they stay stable after that, but increase your risk of heart problems. So what can you do about it? Again, if you're going to start ADT, ideally get your fasting lipids checked at least once. And in fact, now, the most recent North American guidelines suggest you don't even need to be fasting. You can get it checked non-fasting. Fasting is probably still a little bit better, but not a lot. Diet can significantly help reduce cholesterol. For those who are overweight, weight loss. Once again, physical activity. And of course, those men who are high risk of developing heart disease may consider cholesterol-lowering drugs like statins, which a number of you may be on otherwise, because this is a very widely used group of drugs. Okay, so moving on. How am I doing for time? Good. Okay, muscle and fat. I talked a little bit about some of the changes in fat already, but as I mentioned, muscle mass goes down and fat mass goes up, and on average, men going on ADT within the first year will gain about 4 kilograms. The problem is it's not good weight. Not only do we gain weight, but we gain bad weight because we gain fat, and on top of that, some of the fat is gained at the expense of losing muscle. And that's not good, of course, because as men get older, muscle mass tends to go down, and we need our muscles for so many aspects of day-to-day function. There is also breast enlargement in a significant proportion of men who are on ADT, which can be uncomfortable in terms of appearance and sometimes can cause symptoms in terms of pain or a sense of swelling or discomfort. How much do they go up? So the fat mass typically goes up by about 9 to 11%, but at least 1 or 2 studies suggested it may go up 20%, which is enormous. Muscle mass typically drops by about 2 to 5%, but in 1 in 5 men on ADT, the muscle mass will drop more than 5%. And 5% is an important amount of muscle mass drop because that is associated often with fatigue, increased risk of falls, decreased ability to perform day-to-day tasks, decreased exercise tolerance, etc. Breast swelling is seen in 20 to 25% of men who are on injections alone. If you're also on pills, that can go up to almost 60%. And the weight gain is seen in almost 3/4 of men on ADT. So lots of potential effects in the metabolic system. What can we do to try and prevent or manage this? Once again, although this is not easy, diet can help to reduce the weight gain, and weight loss is obviously important for those men who are already overweight or gaining weight on ADT. Easier said than done. I see a lot of these men on ADT. It's not easy to lose weight. But the key thing to emphasize to help reduce the fat and improve the muscle mass as well as help so many parts of our body is physical activity. And there are many different ways of thinking about types of physical activity, but if we broadly divide it up into 3 main categories, which are the resistance exercises or weightlifting, and aerobic exercises or cardiac, or cardio as people call it, and then stretching or flexibility is one simple way of dividing it up. Then the resistance or weightlifting type exercises will really help to build back the muscle you've lost or prevent muscle loss. And the aerobic exercise will help to not only help your heart, but it will help with some of the fat gain and weight gain. So both types of exercise are good, and ideally exercise programs will include both elements. I'll come back to that at the end with a plug for one of our trials that we're doing. All right, last main category is psychological side effects. I'll break this into 2 groups, cognitive and mood. So in terms of cognition, there's a lot of talk about chemo brain for those men who have been on chemotherapy or know people on chemo. A little bit like that is ADT, although the effects are much more mild and controversial. There was a systematic review of 9 early studies of cognitive changes with ADT and found that 47 to 69% of the men in these studies had at least one measurable decline in one area of cognitive testing that was done. And what they did is they did a series of cognitive tests. Some of you may remember this from your undergrad days in psychology, where you have to remember lists of names, or you have to do mental arithmetic, or judge the angle of lines, or rotate objects, or things like that. So different aspects of brain function. So at least 47 to 69% of men on ADT had one area that was affected in a way they could measure. However, a couple of key things to keep in mind. The areas of the brain that were most commonly thought to be affected by ADT were visuospatial, in other words, 2-dimensional and 3-dimensional perception of the environment around you, rotating objects, depth perception, understanding spatial location, driving, those kinds of tasks, and executive function, which is higher order thinking, planning, deeper contemplation, and financial management, those kinds of areas. Significant impact on work, potentially, obviously, for men who are still working. However, we did the largest study so far in cognitive side effects of ADT and found no consistent evidence of loss of cognitive function after 1 year of ADT, and we now have 3-year data, and again, no consistent evidence of loss. So the jury is still out. Why is that? Why is there so much controversy? Well, the studies that were done, including mine, but the ones that were done earlier, were limited because they had very small sample sizes. The smaller your sample of men on the study, the more likely you will have errors in some of your findings because there is imprecision in the estimates. The findings were not consistent across studies. Some studies said it's memory. Some studies says it's language. Some studies says it's visual spatial. They didn't always agree. Some studies found that they improved in some areas. So there remains controversy and inconsistent findings. And not all of these studies had control groups who did not have ADT or did not have prostate cancer. So we don't always know if it's the ADT or the fact that they're getting older, because we know that as we get older, our memories are not as good as when we were younger. And not all of them controlled for the fact that the more times you do testing, the better people get on these tests. We learn, because we're all able to learn and do better. So, whoops, down one slide, please. Thank you. Up one slide, sorry. Okay, so the bottom line at this time is that the effect of ADT on cognitive function is unclear and inconsistent in the average patient. There may be exceptions, but in general, on average, these studies have not consistently found cognitive side effects. There may be a small effect in two areas of function, so visual, spatial, and executive function. And if these effects exist, as I mentioned, on average, they are likely small in terms of the average person. There is no good data to date suggesting there is an increased risk of developing dementia, Alzheimer's, etc., while on ADT. Although one study suggested that might be the case, but that study had some very serious limitations. How do we prevent or manage this? Well, because we don't even know if it's real, we don't really know how best to manage it. General recommendations for good brain health in people who want to prevent Alzheimer's and other dementias, because this is a lot of what I do in my non-cancer world. We know that regular physical activity helps to prevent cognitive decline. We know that mental exercises or brain games, whether on the computer or pencil and paper, stimulate the brain and can help keep the apparatus working well and reduce the risk of cognitive decline. We know that maintaining an active social network with people around you that you interact with and engage with can reduce the risk of developing dementia. We also know, for those of you who are interested, that one of the best exercises seems to be line dancing. I don't know why. You may laugh. But there are studies that show that of all the physical activity, line dancing seems to be very good at preventing people from getting Alzheimer's. I don't know why. And I don't do line dancing, but I'm told that it's not that easy to learn it and to be able to figure out the steps. And so maybe you're using your body and your brain. I don't know. Are there any line dancers in the room? Nobody wants to admit it? Fine. If you are worried about your cognitive function, you think your memory is changing, you don't know if it's just age or other things, by all means, talk to your doctor and get tested. But the majority of patients who get tested, if they even have any cognitive decline, it's probably not from the ADT, it's probably from other factors. So we need to keep that in context. In terms of mood, a number of men on ADT describe changes related to feeling more emotional, more easily crying, sometimes more irritable, and it's up and down. It's emotionally labile. They don't feel as in control of their emotions like they did before they started ADT. They'll cry in movie theaters when watching movies, chick flicks that they wouldn't have cried at before they started ADT, and things. It's more like some of the changes that their wives or partners may have gone through around menopause, or they may feel more in touch with their emotions, but not always comfortably in touch with their emotions because they're unpredictable. And some men report a worsening of mood on ADT, and this has been noted in studies almost 20 years ago suggesting there may be worsening mood and depression. But the actual data supporting an impact on major depression are conflicting and small. One large US study is published just in the last 6 months this year, within the last 6 months of today, and suggested in the US that men on ADT seem to have a higher rate of being treated for depression by either medications or psychotherapy by a mental health professional, and a higher risk of being admitted to hospital with severe depression. So there are some data suggesting there may be an increased risk. How high is that risk? Well, we don't completely know. Some studies have suggested over several years there may be a 10 to 15% increased risk of developing at least some depressive symptoms. Some studies, including one that we did, suggested the risk may be closer to 5%. But there does seem to be a measurable, slightly increased risk in a number of men. So it's something for men and their partners to be aware of. What to do about it in terms of prevention or management? Well, it's not that different at this time compared to men who are not on ADT. We know that men who have mild symptoms, the important things are physical activity. You're going to think I'm an exercise nut. Everything is physical activity, but it helps so many things. There's actually clinical trial evidence that physical activity helps mild depression, but not in patients on ADT, in the general middle-aged and older population. But that may help here. And maintaining an active social network and reducing the risk that you have long periods of loneliness. Having a good support network, whether that's family, friends, networks like PCCN or others that you trust and can talk to, is thought to be an important factor to help people feel connected and not alone when they're struggling with a disease like prostate cancer. If people have more intense symptoms and they feel that these are impacting on function, seek professional help, because there is ample evidence that talk therapy or psychotherapy, as well as medications that are used to treat depression in men who don't have cancer, are equally effective in men on ADT. And we have a lot of options to help. Okay, I'm getting to the end. I think my time is, I'm doing all right. So last area I'm just going to emphasize for a moment is prevention. And we talked about this, but I'll summarize, and then I'll give a summary at the end. Whoa. So when you're starting ADT, a big reminder that there are a couple of key things you can do. Get your bone density checked, make sure you're on adequate calcium and vitamin D, and maintaining physical activity. That'll help your bones. Make sure you get your blood sugar checked, fasting blood sugar, and make sure that you are on a healthy diet and are physically active, particularly if you are at that borderline increased risk of developing diabetes. And check your fasting cholesterol. Make sure that you have good lipid levels, and if you need to, diet and again physical activity and weight loss can help deal with these. These are the ones we can prevent the most, and notice how prominent physical activity is in all of these. Which leads me to spend just 2 minutes reminding you, when Winston introduced me, I was involved as the main investigator on a phase 2 randomized controlled trial of exercise and an economic analysis of 3 different methods of exercise to help prevent and treat some of these side effects of ADT. Because if exercise could be bottled as a pill, we would make billions. And we could help an awful lot more people than we do with some of the pills we have on the market. But unfortunately, exercise is not a pill. It's not that easy to pop it and just sit down with a glass of water and get all of its effect. Although if you believe the manufacturers of those vibrating platforms, you just stand there for 10 minutes a day and you will be cured. One of them actually has threatened a lawsuit against me and my colleagues because we did a study. Anyways, that's another story. We did a study looking at how effective they were in women not on ADT. And we didn't find very good effects, but that's a separate story. We did that phase 2 trial. The study is finished. We're analyzing our data. But in the spring, we will be opening up the next phase of the trial, which is a bigger trial involving multiple centers. So I will remind you that there are now at least 12 different studies of exercise in men on ADT, with programs of exercise that go from 8 weeks to 24 weeks that have shown that you can reduce many side effects of ADT. You can improve quality of life, feelings of function, energy, vitality. You can improve fatigue. You can improve muscle mass. You can improve physical function. You may be able to improve their weight and their muscle fat balance. You may be able to reduce the risk of diabetes. You can improve blood pressure. You may even improve bone density. Show me a pill that can even do 1/3 of all of that. Find me one. You can't. They're not out there. Our goal in this phase 3 trial that will be opening up in a couple of months is to determine the most effective and sustainable and least resource-intensive exercise program that allows men on ADT to be able to exercise and build up their physical activity to get all of these wonderful benefits. What we're going to do is we're going to look for 300 men in 5 centers in Ontario and Alberta, and we're going to randomize them to either a group exercise program where they're coming in 3 times a week for a supervised group-based exercise program of an hour at a time with aerobic and resistance and flexibility training, supervised by a certified exercise physiologist or kinesiologist registered in Ontario. And they are expected and they will be taught different exercises for a span of 6 months, or they will be in a home-based program where they will get support to be able to do exercises at home with the aid of a health coach and technology. So the group program, as I mentioned, are small groups, 2 to 6 people at a time, held at Toronto General, hopefully at Sunnybrook in the next couple of months. South Lake Hospital is going to open up soon, Hamilton and Calgary. So 5 sites throughout Ontario and Alberta, small groups, as I mentioned, plus training at home to increase your exercise. And the home-based program will get 3 things: a Fitbit device, a smartphone with an app to be able to help you track your exercise if you are into smartphones and tracking, and a health coach who is a professional who will talk on a weekly basis with you to establish goals and guide you through an exercise program, and meet in person once a month to help you through building yourself a physical activity program that you enjoy and can sustain. And so we're looking for men who are on ADT, who have prostate cancer, who are fluent in English, and who are physically don't have severe heart, lung, or bone disease, and are not already very active. If you're already physically active and getting at least 150 minutes a week of exercise, fabulous. Unfortunately, you're in the minority of this audience, and I can see you. I know who you are, and the rest of you aren't doing it. You need to do more. So if you're interested, we will be opening up this study in the spring. So to summarize, ADT is widely used to treat prostate cancer. I didn't give you a statistic. 40% of men with prostate cancer at some point in their life after diagnosis will get ADT for some period of time. 40%. So 2 in 5 of the men in this audience. Very widely used. There are many side effects, but a number of these side effects can be prevented or reduced with a variety of interventions and approaches, the most widely beneficial of which is exercise, but there are a number of them that I've highlighted. When you're starting ADT, get your bone density, your blood sugar, and your cholesterol levels checked, and optimize your cardiac risk factors, because the #1 cause of death in men with prostate cancer is still heart disease. Thank you. Not dismissing prostate cancer, it's important. But we cannot underemphasize the other things that are important in our lives and may do us harm. Maintaining physical health and physical activity are key to many aspects of preventing the side effects of ADT, and really being aware and getting educated like you're doing tonight are key, and I thank you for joining me. I want to acknowledge some of the funding agencies that have given us funds to do some of the research I've been doing over the last 10 or 15 years in prostate cancer, and a number of very, very smart colleagues across the fields of medicine and surgery and radiation and so on. I've had a number of students over the years who've been helping us with various projects, including Koss, who's here now, and Megan, who's a PhD student, and a certified exercise physiologist. So she can get you in shape, because I know 60% of you aren't in shape. I can see you. You don't believe me? Ha. Thank you.